did his residency in medicine at Mount Sinai, followed by his ID fellowship at Einstein Montefiore in the Bronx, and has over 25 years of experience in practicing infectious diseases. He has clinical and research interests in bacterial pathogenesis and mechanisms of resistance, HIV infection, and tuberculosis. He's currently the hospital epidemiologist at Cooper. Dr. Thomas Westover is assistant professor of OBGYN and an attending perinatologist in the Division of Maternal Fetal Medicine. He did his undergraduate training at Georgetown and attended medical school at UMDNJ in Newark, did his residency at UMDNJ in New Brunswick, where he also did his fellowship. He's been a member of the Cooper faculty since 1994. He's former president of the New Jersey Maternal Fetal Medicine Society and is currently vice chair of the New Jersey section of the American College of OBGYN, ACOG. He's chair of the New Jersey Hospital Association's statewide Perinatal Safety Collaborative, and he's also an ACOG McMahon Legislative Advocacy Fellow and a member of the New Jersey Department of Health's Maternal Mortality Review Committee. And last but not least, I think Dr. Feingold gets the prize for making it to one of these. She had an auto emergency this morning, but still persevered. Dr. Feingold's the division head of Pediatric ID, director of the Inpatient Pediatric Unit, Associate Program Director of the Pediatric Residency Program, Associate Professor of Pediatrics at Cooper in the Medical School, and Director of the Southern New Jersey Pediatric AIDS Program at Cooper. She first joined the regional hospital at Cooper in 1994 as an attending physician in pediatric ID. She's had a true passion for activism during the AIDS epidemic, and since it started during her fellowship time at Montefiore in the Bronx, where AIDS was devastating families and communities. She also has a master's in public health, which she completed at Columbia, and during that time she worked as an attending physician with injection drug users and families in a methadone program. She spent a year in Nairobi, Kenya, helping design and build a health clinic outside the capital, and did her second fellowship in pediatric infectious diseases, which was at St. Christopher's in Philly. She received her MD degree from WashU in St. Louis, and she's received numerous teaching awards and recognition from the March of Dimes and AIDS activist organizations, and she's had multiple namings to lists of top docs both in Philadelphia and Southern New Jersey publications. She's also quickly become a much-loved and devoted core member of our teaching faculty here, and wears many hats and helps with many programs. So without much ado, let's welcome our panelists. And the format today is going to be sort of a short lecture format, leaving a lot of room for discussion. By the way, attendance sheets are circulating through the group, so please keep circulating them. Thank you. Henry?
Good morning. I'm going to start off this morning. I get to talk about a lot of that boring virology stuff, and then I'm going to pass this off to Dr. Feingold and Dr. Westover, who are going to talk about the real reason why Zika virus is such an important issue for us. So the title of the talk is The Emerging Threat of Zika Virus. Let's see, here's this. In the context of lots of questions, not as many answers as we'd like, and a lot of guidance that keeps changing and will continue to change. All right, I think you all, if you listen to the radio or read the newspaper, recognize that Zika virus is headline news. And these are some of the headlines, and we'll actually be going through some of these headlines during the course of the talk. My favorite headline is actually the one on the bottom about Pope Francis and contraception related to Zika virus. But we may be talking about that at the end. All right, so some of you remember that about a year ago, I was here talking about Ebola virus disease in the context of emerging infectious, oops, what are we doing here? We seem to be going in the wrong direction. There we go. All right, so we were talking, okay, there we go. It seems to be misbehaving. So we were talking about emerging infectious diseases, and at that time we recognized that Ebola was a big problem, and of course Ebola spread to places where we never expected it to spread, with cases of transmission in the United States and patients who were brought to Europe. In the context of the 1 year since then, we've seen some other emerging diseases. We've seen MERS, which was, or Middle Eastern Respiratory Syndrome, in the Middle East spread to South Korea with a big outbreak in Korea over this past summer. We've seen the continuing spread of chikungunya throughout the Caribbean, and now most recently Zika virus. But just put this in context, this is just one of yet another of these emerging and re-emerging infectious diseases that we're going to be continually talking about as we go forward. All right, so my disclaimer for this lecture is this, okay? So a lot of the things that we're going to tell you this morning are probably not correct. They're correct as we know them now, but things may change. New data emerges, new recommendations come out. It's not that we're trying to lie to you, as perhaps some of these folks are, but we're in fact trying to inform you as the best we can as we know it right now. But that may change. When I gave my Ebola talk last year, nobody anticipated that Ebola would be a sexually transmitted disease that could be transmitted months and months later. We learn new stuff, so what we say definitively at one time may change. All right, so these are our learning objectives for this morning. We're going to talk about the virus and where it came from. We're going to talk about transmission and where it is now and where it might end up. We're going to focus a lot on the complications and most importantly Zika virus in pregnancy, but some of the other complications. We're going to discuss the current guidance on how to deal with pregnant women in the context of Zika virus. And then at the end, we'll probably have time to address some of the complicated issues that arise when thinking about an entity like this that affects predominantly pregnant women and has tremendous implications towards reproductive health. All right, so what is Zika virus? It's a mosquito-borne virus similar to dengue and yellow fever and West Nile and a lot of other flaviviruses. And the predominant vector, which we'll be talking more about later, is Aedes aegypti, which is the yellow fever mosquito. The virus is not new. It was first identified in Uganda in 1947, and like most viruses of that time, it picked up its name from the river that was there. And there have been sporadic outbreaks throughout Africa and Asia through 2007, and then the pace seems to pick up a little bit. These outbreaks are characterized by high attack rates, meaning that once it shows up, a large percentage of the population become infected, and then it moves on, because then most individuals in the population are immune. And it's generally been considered a mild illness, much less severe than dengue, and the complications were not reported that we're seeing now, probably just because they weren't recognized. A lot of these outbreaks were in very rural and undeveloped areas, and nobody put the pieces together about some of the complications that we're seeing now. All right, what do we know about the clinical manifestations? So the incubation period, an onset of symptoms is up to about 2 weeks after you get exposed, and exposure is by infected mosquitoes. However, about 4 out of 5 individuals who are infected are completely asymptomatic. If you have symptoms, the symptoms can include fever, a rash, conjunctivitis, or arthralgias, and you can have some or all of these symptoms. And the symptoms generally last anywhere from 1 to 7 days and then get better. Patients are known to be viremic during their symptomatic period, but obviously they're viremic when they're not symptomatic as well. And severe disease requiring hospitalization and fatalities are extremely uncommon, but have been reported. However, one complication I am going to mention, because it's gotten a lot of press lately, is Guillain-Barré syndrome, which definitely has been linked to Zika virus infection. And I'm just going to show you briefly the data about that. This is the same population cohort that Dr. Feingold will be talking about later. Although we're all focusing on the outbreak in Brazil that is now spreading through the Western Hemisphere, there was a large outbreak in French Polynesia in 2013 to 2015. And essentially, 80 to 90% of the population there were infected once the virus arrived. And this just shows you the number of cases of Guillain-Barré in that population. It's an island of about 250,000 people, so they can do very good epidemiologic studies. And you can see the number of cases of Guillain-Barré concordant with the number of cases of Zika virus during that time. And these are patients who were serologically diagnosed. Many of them were asymptomatic. And the rate of Guillain-Barré was about 0.25 episodes per 1,000 cases. If you have thousands and thousands of people infected, then you're going to see cases of Guillain-Barré. All right, so a little bit about what we know about pathogenesis. So you get infected, you become viremic. You can find virus in the blood, usually up to about 7 days during the period of viremia. However, we've now learned that you have even higher levels of virus in the urine, and that virus persists longer in the urine. So some of the testing that we'll be talking about now includes both blood and urine. The virus has been found in a lot of other tissues besides blood and urine, and we'll talk about the implications of some of this. You start to develop IgM responses about 4 days after the viremia. The problem with these IgM antibody responses is they cross-react with a lot of other flaviviruses, including dengue and chikungunya. So if you're in areas where those viruses are also highly endemic, it's sometimes hard to tell what those antibody responses mean. So if you measure virus, that's great, except you only measure virus when you are actively infected. Seroepidemiologic tools that you look at in people who may have been infected a couple of months ago, not so great. This was just an early slide from the CDC looking at the general testing strategies. Somebody who is acutely symptomatic or recently symptomatic, you can look for virus. If they are late symptomatic, you're going to be looking at antibody. And if you're looking for virus, you're going to be looking both at blood and urine now. All right, so let's talk about transmission. This is the major vector, the mosquito. These are mosquito larvae, which are found all over the place in many of these countries where Zika virus is endemic, and tend to collect in standing water. So any place you have standing water, you have opportunity for mosquitoes to breed. And a major focus of control in many of these areas now is mosquito vector control. All right, however, this is my favorite vector. Okay, and this is how Zika virus is transmitted to new places. And this just shows you, that those little blue lines that you see, these are all of the air travel routes between the United States and Zika-infected areas in South America and Central America and the Caribbean. Lots of opportunities for people with Zika virus to get on planes and come to the United States. All right, this just shows you our friend the mosquito and what happens. The mosquitoes bite people. They get virus in the blood. The virus travels through the mosquito, into the midgut, into the circulatory system, back into the saliva of the mosquito. So when it bites somebody else, and Some of that saliva goes into the wound. So mosquitoes are very efficient vectors at transmitting a lot of viral diseases. All right, so what do we know about transmission? The primary mode of transmission is the Aedes aegypti mosquito, which is also the vector of yellow fever and dengue, one of the vectors of chikungunya. A big question is whether there will be other mosquitoes that can transmit this. During outbreaks, humans are the primary reservoir. We don't know of a major animal or non-human reservoir. Infected individuals, most of whom are asymptomatic, can certainly travel. So people carrying virus can go to other areas. However, in order to have a sustained outbreak in that new area, you have to have both somebody who's infected and a mosquito population that is capable of sustaining the transmission, right? So if somebody with Zika happens to fly to Alaska, where it's a little cold and there aren't a lot of mosquitoes, you're not going to get sustained transmission. But if you end up in a place where you have the right kind of mosquitoes, you can get these sustained transmission and large outbreak. We know that there are other modes of transmission. Some of these are theoretical, some of these are real, and we don't quite know how important some of these are. All right, so let's talk a little bit about where Zika virus is now and where it's going. So this is a natural history map of Zika virus. You can see that back in the 40s, 50s, 60s, 70s, mostly in Africa, then kind of moved out into the Pacific Islands. But then as you look along the line down here, you can see moving into the current era, it moved into the Western Hemisphere in the spring of last year and then rapidly spread. So the first description of transmission in the Americas came from Brazil back in May of 2015. We think it was probably introduced in March or April of that year. There's a lot of theories about how that happened, different sporting events. There was a big canoeing competition which had a lot of canoe crews from parts of the Pacific Islands where Zika is endemic. But we have no patient zero to say this is the person who brought it over. Okay. However, between May and December, estimates of up to over 1.3 million infections in Brazil in that relatively short period of time, and now rapid spread through much of South and Central America, the Caribbean, and parts of Mexico. The CDC website, which is constantly updated, I think has 33 countries and territories listed now, 30 of them in the Western Hemisphere. The other thing that they recently put out was the fact that risk is not uniform in different countries. There is an elevation factor. Mosquitoes don't like it, or these particular mosquitoes, over 6,500 feet. So if you're going to Mexico City, that's probably okay. But if you're going to other parts of Mexico, like Acapulco, probably not so good. So will Zika spread to the continental United States, and will it come here? All right, I found this headline, which I thought was rather interesting, about a cluster of these mosquitoes that was found actually on Capitol Hill. I wonder who brought them there. However, we're preparing to deal with the fact that we think that this will end up in Florida. Big controversy there about the use of genetically modified mosquitoes to fight the Zika virus infection, because clearly one strategy is mosquito control. And that guy on your right is an anti-GMO mosquito guy dressed as a mosquito. All right, so this is where dengue is, okay? This is a map of the distribution of dengue, which is the map of distribution of Aedes aegypti. And you can see that that kind of goes through the very south of the United States, parts of Texas, Florida, a little bit of the southeast. However, we have other Aedes mosquitoes besides aegypti, and this is really the big question. Aedes albopictus, or the tiger or forest mosquito, has a much wider range of distribution in the United States. Both of these mosquitoes are considered aggressive daytime biters. They're not evening or nighttime biters. That has something to do with what you do when you protect yourself from mosquito bites. This is the distribution of Aedes aegypti. This is the distribution of albopictus, which is much wider, and you can see certainly includes New Jersey there. And what we don't know is whether other mosquitoes are also going to be relatively efficient transmitters of this virus. We don't think so, but I don't want to lie to you and tell you that we know that for sure. All right, this is just a reminder that Aedes aegypti has been in Philadelphia. The Great Yellow Fever outbreak in 1793-94, which was described and written about by Benjamin Rush, shows that these mosquitoes can find a home in the Philadelphia region. Richard Allen, who was recently honored with a stamp in this year's Black History Month, and was part of the response to the yellow fever epidemic in Philadelphia during that time. All right, so let's talk a little bit more about transmission of viruses. I show this slide because of a couple of things. One is that people with viruses get on planes and travel. However, it also talks about sexual transmission, okay? So what do we know about sexual transmission, and how do we know it? So we know that there are confirmed cases of Zika virus infection in women who have never been to a Zika endemic area whose sexual partners have. This includes at least several confirmed and some probable cases, and this database is being updated, and includes transmission to pregnant women, okay? So far we haven't seen reverse transmission, but nobody would know to look. And we know that most infections are asymptomatic anyway. So the magnitude of this problem really is not clear. And the CDC is still struggling to give us clear guidance on how to address this particular issue. When we focus on pregnant women and the risk of Zika virus, there's the risk of sexual transmission from potential asymptomatic partners. So what do we know? Is Zika an STD? Well, by the strict definition, it is. You can acquire it through sexual transmission. How common? We don't really know. How come we didn't know this before? Because in the midst of an epidemic, most people are infected by mosquitoes, so those few cases that occur by sexual transmission, you'd never know about. And probably there are other viruses that may be sexually transmitted as well as transmitted through mosquito vectors. We know that the semen is a protected reservoir for virus. For example, we know in Ebola people can carry virus in semen for months and months and months. And we know that so far Zika has been documented in semen for as long as 62 days, and those studies are ongoing. Does this happen in some men, in all men? I don't think we know any of those answers yet. Okay? We also know that Zika can be transmitted through blood. And this is obviously a problem when you have people who are completely asymptomatic, like West Nile, which is a problem for our blood supply now, who may donate blood because they don't know there's anything wrong with them, and that is risk for transfusion-associated cases. They can be clearly documented in Brazil. So the FDA and Red Cross have laid out recommendations that say do not donate blood for up to 28 days after a return from a Zika-affected area. That's going to get even messier when that Zika-affected area territory begins to grow. Okay? Then we're going to talk mostly for the next few minutes about vertical transmission and congenital infection, and I'm going to pass this off to Dr. Feingold and Dr. Westover. You want this?
Thank you. If you don't find what I'm telling you now interesting, you can ask me about what it feels like to drive over a telephone pole in a Prius. We can talk afterwards, okay? Because I just had that fascinating experience. Anyway, so the concern, of course, was that early in the Brazilian outbreak that people started to describe the association of Zika virus with what you see here, microcephaly. And, there's a lot of argument about there's been concerns, are there other things going on? And there may well be, because, and we just don't know yet in great detail. But there are some pretty robust studies that have demonstrated, for example, in abortuses and stillbirth, the presence of Zika virus in the tissues as well as in the brain. So I think it's pretty clear that this is part of the manifestation of this infection and a risk to the fetus. So then immediately the question becomes, well, how big is this risk? And in the most recent literature about brain and in particular CNS abnormalities, scientists have been trying to figure this out. So there was a recent article in The Lancet where they reanalyzed the outbreak data from the Polynesian epidemic, and they used serologic surveillance to estimate the probability of infection with Zika virus for each week of the epidemic, and then they searched medical records to identify all cases of microcephaly. And using a mathematical model, they felt that the data suggested that the period of risk was a best fit for when the mom was infected in the first trimester. And all the data that they did an extensive retrospective review, they came up with a risk of about 1% for microcephaly associated with infection in the first trimester. Again, this was retrospective, so there was really no description of any of the symptomatology. This, strongly sort of compares with what the data that's coming out of the most northern state in Brazil, and they described during 4 months of the epidemic that 2% of all the neonates were suspected cases of microcephaly. And these were infants born not only to women who were symptomatic, but to women who weren't even known to be infected necessarily, so might have been asymptomatic. So the bottom line is we don't know. The denominator's not clear, and even the numerator's really not clear. So the definition of microcephaly has changed. It looks like in Brazil in particular, where we're getting the most data, they're trying to cast a very wide net to pick up babies that might be affected. And again, they're using at this point only microcephaly, and there may be other brain abnormalities or changes that are occurring that we're not detecting. So in order to try to answer this question a little better, there's some very early data from Brazil that was published on March 4th in the New England Journal of Medicine. And what this group in Rio de Janeiro did was enroll pregnant women in whom rash had developed within the previous 5 days, and then followed them through their pregnancies. They tested blood and urine for Zika by RT-PCR, and they followed the women prospectively. They collected clinical and ultrasonographic data. And they collected 88 women in this study from September of 2015 to February of 2016. 82% turned out to be positive for Zika. And the infection occurred at any time between 5 and 38 weeks gestation. They were able to perform serial ultrasounds in 42 of the Zika positive women and all of the Zika negative women. And that's because some of the Zika positive women either lived too far from the center to get the ultrasounds, or actually actively chose not to have ultrasounds because of the fear of hearing about an abnormality. And they reported that 12 of the 42 positive Zika positive women, or 29%, had some abnormalities. Now there's a lot of data on this slide, but I just use it to show that, first of all, it's a very small study. There's outcome data that's still not available, but you see that the description of the abnormal studies, including descriptions of microcephaly, cerebral calcifications, and intrauterine growth restriction. They also reported 2 fetal deaths that occurred quite late. So there were 2 stillborns at week 30 and week 38. You know, the study's not complete by any means. There may be other things going on that they haven't excluded, but nonetheless, the preliminary numbers are clearly quite worrisome. And the fetuses or the moms who had abnormal findings on fetal ultrasound occurred, you know, throughout the pregnancy, throughout the weeks of gestation. So, you know, the question of, is it worse in the first trimester, or is it really only significant in the first trimester, you know, seems unclear, but at this point I think there's concern that things can go poorly for the fetus throughout the pregnancy and even in the second and third trimesters. So people have raised this question, well, is then the microcephaly really just the tip of the iceberg? And are there other brain abnormalities and migrational abnormalities in particular that could, you know, be the result of this infection? And that, you know, when we identify infants with microcephaly, we're only seeing part of the spectrum of the result of Zika virus during pregnancies. And again, this idea that that infection at any point in the pregnancy may have a negative impact on the fetus. The researchers in Rio de Janeiro found that microcephaly was mostly associated with having restricted growth during the pregnancy. So, you know, as a result of the infection, there was placental insufficiency and poor fetal growth. And they also described this high, you know, rate of fetal death. Again, their numbers were very small, but so this is really still very preliminary. But they really felt that their study thus far supports a link between maternal Zika infection and fetal and placental abnormalities, similar to other viruses that we know can cause congenital infections, and especially they worry about intrauterine growth restriction and placental insufficiency as a result of Zika during the pregnancy. So I'm just about to finish up here so that we have time for questions and Dr. Westover's presentation, but what is the formal recommendation thus far for evaluation of infants with either positive or inclusive Zika virus tests? You know, it's not so dissimilar to what we do for every baby, which is a careful physical exam. Obviously, we want to look very carefully at the head circumference. Cranial ultrasound if it hadn't been done in the third trimester. Some of these infants are turning out to have macular abnormalities, so an ophthalmologic exam, newborn hearing screen, and then, you know, a very focused look for neurologic abnormalities, dysmorphic features, and anything suggesting in utero infection. And full body photos, since we need to build a database about what these infants, you know, are presenting with. And for infants with microcephaly or intracranial calcifications, any abnormal neurologic findings, you know, in having a pediatric geneticist or dysmorphologist evaluating the infant, as well as pediatric neurologists and pediatric infectious disease. The routine labs that one would get for any infant suspected of congenital infection, and then importantly ruling out other congenital infections that we know can also lead to CNS damage and microcephaly. And I just wanted to end about, you know, sort of the less strictly medical aspect, which is, you know, ultimately, you know, these outbreaks are occurring and being described primarily in you know, very poor areas in Brazil, and where poverty rates and mosquitoes tend to be the highest, and you know, we need to start thinking about providing for these families and infants and making resources available. Thank you.
So good morning. Henry and Annette gave their disclaimers. My disclaimer is that both of my daughters are currently in South America, and my wife is going to visit them in a month. So I'm feeling real happy. So the CDC has ongoing communications, which is a great resource for the American College of OBGYN, Society for Maternal Fetal Medicine, American Academy of Pediatrics. The downside is that the CDC has an ongoing source of information for us that's constantly changing. So they're using MMWR as a resource to post information. There is basically a team of physicians that are linked between the American College of OBGYN as well as the CDC. They put publications out in our Green Journal, and they have an active website. And basically we're being emailed almost on a weekly basis with practice advisories that unfortunately do sometimes change practice paradigms as we move forward, which is okay as we learn more information, as Henry said, but sometimes we're counseling a patient 1 month and literally have to kind of keep a log of those patients so we can recontact them the next month with a slightly different paradigm. So this is the most current CDC ACOG summary of updated guidance, and they are now recommending, basically when they first came out, their recommendation was to only do serologic or PCR testing for patients who were symptomatic. They acknowledged that 80% of patients were asymptomatic, and they caught a lot of feedback, I think, not necessarily positive, that we were essentially ignoring the patients who were asymptomatic. At least ignoring them until birth. And so there were a lot of patients and clinicians who were not happy with that recommendation. So they modified it, and the current recommendation is to do antibody testing for all pregnant women who have traveled to an affected endemic area, regardless of the presence of symptoms. So originally the recommendation was only to test patients with positive symptoms. The recommendation is also to antibody test for patients who are living in an infected area. So we have two different kind of sets of populations, right? One who's just traveled one time or several times, and then the other patients who are actively having a lifestyle in that area. They certainly have commented that just like all kind of inclusive reproductive life planning or family planning issues should be discussed during interactions with patients. This is something that OBGYN physicians and nurses do all the time, to talk about whether you're planning pregnancy or whether you're using family planning methodologies, various contraceptive methods. Certainly is an important ongoing information to have, and that currently we have to talk about sexual transmission as well. There is concern, or there was concern about, well, if you became infected, currently, was that going to have an impact on future pregnancy? And we're currently counseling that we don't think that that's going to have an effect. So they've basically kind of broken out the paradigm. We'll show two figures, or two algorithms, if you will. The first is with a patient with a history of travel to an area with ongoing Zika transmission. So they're recommending PCR testing for those with clinical illness, as Henry mentioned before, fever, maculopapular rash, arthralgia, or conjunctivitis during or within 2 weeks of travel. Of course, we don't know what the sensitivity is of these tests. Henry mentioned that the specificity can be unclear because of cross-reactivity between other viruses. And then for patients who are traveling but without clinical illness, then the recommendation is to offer IgM testing within 2 to 12 weeks after exposure to travel. The problem is some of these patients traveled several months ago. They're outside the 12-week range, and then it's kind of unclear as to whether or not you should test those patients at that time or simply offer them ultrasound. So this is the updated algorithm as of February for pregnant women with a history of travel to the area. I don't know if an arrow, yep, here's our arrow. So here's our pregnant woman with a history of travel to an area that's endemic. basically to test for Zika virus infection, depending on whether or not they're symptomatic with PCR or asymptomatic with IgM. If they are positive or inconclusive for Zika virus infection, then the recommendation is to do serial fetal ultrasounds. We don't know really how frequently to do those ultrasounds. It's been suggested that they be done at certain kind of key gestational ages. The traditional time that we do ultrasounds for anatomic survey of the fetus is about 18 to 20 weeks gestation, and then to do them at least probably every 4 weeks throughout the late second and third trimester. To consider an amniocentesis for Zika virus testing, although we don't know the sensitivity of amniocentesis for viral isolation, nor do we really know how long the virus is shed or how long you can detect viral particles in the amniotic fluid. The other problem is just because you have infection doesn't mean you have affliction. So we don't know what the positive predictive value, the old kind of corollary of, does the genotype predict the phenotype? That we don't know. We don't know what the false positive rate is for these things as well. So we're kind of working in a little bit of a black box, obviously. Because we don't know the sensitivity of the IgM for viral infection, and because some patients will fall outside the window, there will be some patients who will be quote-unquote test negative, but still may or may not be actually infected or status post-infection. So there's still a recommendation to do serial fetal ultrasounds. Probably don't need to be used with the same frequency or intensity. Probably we should be offering more reassurance to those patients. But you still need to do those ultrasounds and then base your subsequent imaging based on the fetal ultrasounds as well as the pediatric exam in the newborn period. I won't go through all of this as much, but this is basically the algorithm that's based on for a pregnant woman who's currently residing in an area with ongoing Zika transmission. So this is probably going to be occurring at least for U.S. citizens more and more in Puerto Rico. And the problem is that you're not going to keep testing the patient every week or every 2 weeks for antibody levels, right? You're just not going to do that. So it's going to mostly relate to serial fetal ultrasound surveillance. One of the core problems, obviously, is that we don't have a therapy to offer these patients. So you're just kind of sitting there nervously waiting for your child to be born. So basically, the fetal evaluation is broken into two parts. One is to do serial ultrasounds. Seems reasonable to obtain the first ultrasound probably about 4 weeks or so after exposure or symptoms, or at least at 18 to 20 weeks gestation, which is the kind of the time frame that we would normally do what we call a fetal anatomic survey. The ultrasound should focus on findings such as intracranial development, neural development. Obviously, there's a lot of neuronal migration and neural development that occurs in the second and third trimester. But just because you don't find something on an early scan doesn't mean that you don't have microvascular destruction or disease occurring that you can't see in an ultrasound. So serial ultrasounds are important because an early reassuring ultrasound may not preclude later manifestations of disease. And we certainly have seen that with other infections such as toxo, CMV, syphilis, etc. The problem with the amniocentesis PCR is we really don't know the sensitivity. We don't know if the fetal recirculation of virus is different than the maternal recirculation. We don't know if the fetus continues to shed virus, if there's ongoing fetal disease. So there's a lot more questions than there are good answers at this point in time. We talked a little bit about considerations, just family planning considerations. Clearly, OBGYNs is just kind of part of their general existence, talk about pregnancy intendedness, talk about family planning, talk about contraception. There's a lot of issues that should probably be discussed, especially in endemic areas, during preconception care. There's been recommendations by various bodies to talk about, delaying pregnancy for some extended period of time. Is Brazil, as some of the other South American countries, going to have a major fall off in birth rates because people are actively deferring pregnancy? We really don't know that at this point in time. About half of all pregnancies are unintended in the U.S. 2 of my 3 kids were surprises, so there you go. I'm a government statistic. It's unclear what the intendedness is in the South American or Central American populations, but clearly because of the strong influence of the Catholic Church in those areas, there are access and educational issues related to availability, safety, and acceptability of contraception. Henry talked a little bit about sexual transmission. Breastfeeding is a separate issue. Right now, there's no known detriment to breastfeeding. Breastfeeding is a important source of bonding and newborn nutrition in many rural or underdeveloped areas in developing countries. And right now, the recommendation is that patients breastfeed. There's not a specific recommendation, as far as I know, whether or not you should breastfeed during active infection, so that has not really been fully addressed either. So what do we advise? How much do we scare patients? How much do we reassure patients? These are all questions that we're dealing with on the front lines during prenatal care. Certainly we are counseling patients about the potential downside of microcephaly and the potential adverse impact on neurocognitive outcome, about the potential for fetal demise. The incidence of vertical transmission is unknown. It's not actually clear how much epidemiologic data the CDC is collecting. It's not clear if they're going to link them to birth certificate data or other kind of population-based longitudinal registries to see this impact in the U.S. So these issues are difficult to deal with. A fetal infection can occur in any trimester. Many of the major viral or parasitic illnesses are associated with a greatest risk in early pregnancy exposure, but it's not clear, as Annette said, how much that risk falls off later in pregnancy. And the core problem is that there really is no vaccine or treatment at this point in time, and termination of pregnancy. Not only is it a political football in the United States, but it is always, it's even bigger issue with terms of access to safe abortion care in Central and South America. There are countries in Central and South America where it is illegal to perform abortion for any reason. So the ethics of abortion care, the controversies, both medical and social, are all problematic across the world. There have been a number of articles written in Lancet and other major journals talking about, how do you deal with these reproductive health issues. Henry mentioned, the Pope making comments on contraception being appropriate or not. These are cultural issues we all struggle with. So clearly, avoidance of affected areas is both, despite my family's intent to visit South America on a regular basis, apparently. And we have patients literally contacting us every week saying, my grandmother's having her 50th birthday, or, my cousin just had a birth in South America, I'm going to visit her, and it's very difficult for families to ignore important life events. And so we have pregnant patients still visiting, American pregnant patients still visiting these countries. So we give them guidance on avoidance is the best prevention, if you will. You can use EPA-approved mosquito-containing repellents such as DEET. You can use permethrin, enriched clothing. If possible, you try to minimize your exposure to standing water, but how beneficial that is, it's unclear. There is a paradigm that's been developed through the CDC, through the lab in Fort Collins, Colorado. You do have to go through your county health department at this time. There is a direct link into the New Jersey Department of Health as well, too. So you do have to link directly with them. There are a couple state labs that are doing testing. And currently, they're collecting serum and urine and talking about, how we sample placenta or amniotic fluid. There is a form, there's a bunch of demographic information we have to fill out. There is a form, where's my form? Oh, never mind, this guy's not there. There's a form you have to fill out. You have to get an approval number from the state before you obtain your samples. One of the problems with this whole diagnosis of microcephaly is it's not actually that well defined in either the obstetric, in the obstetric population in particular. So to use the less than the 5th percentile, 3rd percentile, number of standard deviations, the Society for Maternal Fetal Medicine came out with a statement that basically said the more severe the microcephaly, the more likely it is to be truly present in the newborn, and the more likely it is to be pathologic and a result of some fetal disease. There are some specific ultrasound findings you can look for to help with that process as well. This is not an acute disease, right? So there is no medication we're going to give the patient if they come down with symptoms or if they're diagnosed with an acute illness. They're not going to be hospitalized. It's not an obstetric emergency. They're not going to be admitted to labor and delivery. It's outpatient management in the absence of some severe maternal decompensation. So there's lots of unanswered questions. We're receiving information literally on a weekly basis. It continues to change. And the key is basically to optimize awareness and education. There is fear in our community, both from the physicians as well as the patients. Patients have a varying risk tolerance for having a perfect baby or non-perfect baby, and there's certainly a question or a concern that patients may consider or choose to terminate pregnancy without having severe fetal disease be present. So it's an issue. Do you want to come back?
Thanks. So we're going to open it up now for questions. I think that obviously we can't really answer all of these societal questions, but there are lots of implications for what's going on. We know that Zika is poised to spread through Puerto Rico rapidly over the next few months. They expect that a quarter to a third of the population will be affected. Those people are part of our community here, and so this is something that's going to impact even more clearly on all of us here. So we're all going to take questions if you have some.